I thank the organizers for giving me this opportunity for speaking here on this topic of cardiac medication in non-cardiac surgery. Most of us, even being cardiac anesthetists, we also, many a times we do cardiac patients coming for non-cardiac surgery. Quite often we deal with this type of patients. So if you see, there are about 250 million major surgeries are performed annually worldwide, and cardiac complications constitute the most important and common cause of postoperative morbidity and mortality. And 30-day mortality is associated with moderate to high risk cardiac surgeries is about 2 to 5%. It's quite a bit of high mortality even compared to cardiac cases themselves. And coming to the medications in the perioperative period, the cardiac medications, over 50% of patients undergoing surgery are on some chronic medication therapy. Most of the patients, more than half the percentage of patients are on some or other form of medication in the preoperative period. So who manages these medications is always a confusion. The surgeons, anesthetists, and the medical consultant whom the patient is consulting before together manage these medications in the perioperative period. This is where the confusion comes. Sometimes, as an anesthetist, for example, if we are worried about the hypotension and we ask the morning dose of ACE inhibitor to be held, but cardiologist gives the opposite view. He says, no, I want the medication to be started, and surgeon gives a NBM order. So the nurse is in the end confused whether to give or not to give. So unless there is a communication among the team members, there will always be confusion whether a certain drug to be given or not to be given or continued. So all of us know that continuing a drug in the perioperative period, especially the cardiac medications, can compromise on hemodynamic stability and also can interact with the anesthetic agents and also lead to postoperative complications such as bleeding, hypotension, and leading to acute renal failure. On the other hand, sometimes discontinuing medications in the preoperative period may lead to withdrawal syndrome like severe hypertension, or sometimes the cardiac failure can be precipitated. Coming to the most common drugs in the perioperative period in cardiac patients, most of the patients are, especially the ischemic group, are on one or other beta blockers in the preoperative period. So there are guidelines what to do about this beta blocker therapy, whether to continue or to discontinue. So how did this beta blocker therapy become so prominent in the surgical group of patients in general? It's the initial interest of using beta blockers to prevent the postoperative cardiac complications was supported by small number of randomized control trials and reviews, especially this landmark paper by Mangano et al. That is where the role of beta blocker has been established in the non-cardiac surgery. So perioperative beta blockade was quickly adopted, and because of the potential benefit was large. At that time, not many other group of drugs are there in early 90s. The beta blockers are the mainstay in the ischemic management, apart from, of course, nitrates. So, but there were some controversies about this beta blockade. So initial data was mainly derived from a small trials with minimum power, and it was also used in selective patients like only in vascular surgery, and agents used were atenolol and oral bisoprolol. So limitation of these initial studies provided rationale for further studies. So there a lot of studies were conducted, and some of the studies, especially 3 studies, showed no cardiac outcome improvements on mortality or the mortality difference between beta blocker treated patient and untreated patients. Based on this controversy, then a major trial was conducted, that's the POISE trial. But this also has been criticized for using high dose of long-acting beta blocker for initiation of the dose, and it was not titrated. So POISE trial also was not a very well conducted trial. It has its own critics. So all this left us with a confusion whether what to do with a beta blocker therapy, whether we should initiate a beta blocker therapy in high risk patients or to stop the beta blocker therapy if the patient is on all. Based on all this, the American Heart Association has issued the guidelines. So these are our concerns, whether to continue beta blockers. If you continue beta blocker, there is less chance of cardiac ischemia, will have better heart rate and blood pressure control, and also we can avoid the withdrawal syndrome. Whereas continuing beta blockers, always we have as anesthesia, especially when we are giving central blocks, central neural blocks, there always can be sympathetic blocks, there can always be a severe hypotension and bradycardia. There is always concern to continue, whether to continue these beta blockers or not. So 2014 guidelines, AHA guidelines have been quite clear, and now we have a clear-cut guidelines what to do with the perioperative beta blockade. So if the class 1 recommendation is beta blockers should be continued in patients undergoing non-cardiac surgery who have been on beta blockers chronically. Suppose the patient is on a chronic beta blocker therapy for either hypertension or for ischemic heart disease, it should be continued. This is very clear. There is no ambiguity in this. If the patient is already on pre-existing beta blocker therapy, please continue the beta blocker therapy, including the morning dose of beta blocker. That's very clear. So what about the other recommendation? It is reasonable for the management of beta blockers after surgery to be guided by clinical circumstances. Suppose the patient is on beta blocker, a higher dose of beta blocker, for example, 100 milligrams of metoprolol, 50 milligrams in the morning, 50 milligrams in the evening. Then what we should do, whether we should continue the same doses or not. In the perioperative period, because of the fluid imbalance and other things, the patient may not tolerate such high dose of beta blocker. In that case, it is reasonable for us to titrate based on the clinical circumstances, independent of when the agent has been started, whether agent has been started 1 week before or 10 years before also. We should, in the post-operative period, we should be careful with the usage of the beta blockers. Coming to the other guidelines regarding the beta blockers, if in patients with high risk or intermediate risk of myocardial ischemia in the preoperative risk stratification test, suppose when you do the pre-op assessment of these patients and you find them that they have a higher risk because of the age, because of pre-existing or from the stress test and other things, you realize that this patient has got a higher risk of myocardial ischemia, but he is not already on beta blocker. Suppose you see this patient about 5 days or 1 week before surgery, what should we do? We should begin, it is reasonable to begin the perioperative beta blocker therapy, but level of evidence is little less C. But if there is a high risk, then it is prudent on us to start a beta blocker therapy. But next question comes when to start. I'll come to that. And also class 2B recommendation is that in patients with 3 or more risk factors like diabetes, heart failure, coronary artery disease, renal insufficiency, CVA, it may be reasonable to begin beta blockers before the surgery, because these are the high risk cases for a intraoperative or perioperative myocardial ischemia. In this group of patients also, it is reasonable to start if the patient is not already on beta blockers. And coming to other recommendation, if patient with a compelling long-term indication for beta blocker therapy, but there is no other risk factor, initiating beta blocker in the perioperative setting is as an approach to reduce periop risk is of uncertain benefit. So if there is no great risk here, it may not be appropriate to start it. Coming to the next recommendation, in patients in whom beta blocker therapy is initiated, it may be reasonable to begin beta blockers long enough in advance to assess the safety and tolerability. So, if you are to start a beta blocker in a patient, start it early, not on the day of surgery. The guidelines are very clear. It should not be started on the day of surgery. If you are to start, you have to start at least 2 to 7 days before the surgery, definitely not on the day of surgery. So, here coming to the harm of beta blockers, if the beta blocker therapy is started on the day of surgery, it does harm. Apart from not doing any benefit, not giving any benefit, it can actually cause harm. So, this is about starting the beta blockers and who are on beta blockers. What about withdrawal of beta blockers? Very few studies describe the risks of withdrawing beta blockers in the perioperative period. But the long-standing evidence from other settings suggests that abrupt withdrawal of long-term beta blocker therapy is harmful. So, if somebody is on long-term beta blocker therapy, please don't withdraw abruptly in the preoperative period. So, that is about beta blockers. So, the take-home message is, if the patient is already on beta blockers, please continue it. If he is not on beta blockers and if he is high risk of developing a perioperative ischemia, start the beta blockers, but start them early, not on the day of surgery. If the patient is already on beta blockers, please don't withdraw them abruptly. These three are the take-home messages on the beta blockers. And coming to the other important drug, aspirin. Aspirin nowadays, if you see any patient coming for any surgery, you see already they are on antiplatelet medication, some or other antiplatelet medication. Sometimes aspirin is given as a primary prevention, sometimes as a secondary prevention, sometimes already existing stent or something also they use. So, clearly nowadays, if you look at any prescription of any patient, whether he is a hypertensive, he is a diabetic, he is a CVA patient, he is a peripheral vascular disease, everybody will be on statin, on a beta blocker, on a statin and a aspirin or clopidogrel. This combination is very, very often you find it's very difficult to see a patient who is not on any of these drugs if they are past 50 years of age and all. So, aspirin is one of the common medications the patients are on because of various indications for aspirin. So, previous practice used to be to discontinue aspirin 5 to 7 days before a surgical procedure to prevent bleeding, because that's what I said in the beginning of the talk is that the goals of three physicians who are dealing with the patients is different. The surgeon always his primary concern is bleeding. He is not bothered what happens to the patient. He doesn't want to get a bad name from the patient saying that there is a lot of bleeding. So, surgeon's concern is always about bleeding. The cardiologist will say, I don't know, don't stop the antiplatelet. If you stop, the patient is going to die. So, you have to balance between the cardiologist at the one end and the surgeon at the other end when to stop, because if you tell the surgeon to postpone the case, he will get upset. He will say, no, this patient, this hernia is getting obstructed, anytime it will strangulate, I have to do today itself. So, based on this also, when you plan, because many of us, when we do this type of cases, probably some of us prefer regional anesthesia. So, we have to take care of our needs also in the regional anesthesia, because in presence of antiplatelets, if you give epidural and then if you land up with epidural hematoma, then you are liable in the courts, legally you are liable. So, you have to balance between these three things, your own risk with the patient and the surgical risk or the surgeon's opinion, because here everybody has got their role in this. You cannot just push out somebody saying that, oh, cardiologist has got no role. No, because the patient is being treated by cardiologist all these years. He has just come to us. So, we cannot also give an opinion. Suppose we say stop the antiplatelets. The patient will blame us tomorrow if there is a stent block or something. So, based on all this, we should go with a consensus among the treating physicians. That is where the communication and consensus is very important. We should see whether the bleeding is will do more harm, or whether stopping of the antiplatelet will do more harm. Because antiplatelets, once again, are double-edged weapons. They can, if in excess, they can cause problem. If you don't give, that can. Other problem of sudden withdrawal of these antiplatelet agents is also the rebound thrombosis, which can occur. So the patient is on a chronic therapy with aspirin and clopidogrel. Suddenly you stop it, the patient can develop a thrombosis. So you will be blamed for it in the perioperative, if any perioperative event happens or intraoperative event happens. So, but the recent studies about recommendations about aspirin are advising aspirin to be continued in the perioperative period, even on the day of surgery, if the relative risk of bleeding is not much. The exceptions for this are mainly the intraocular surgeries and the neurosurgeries, and probably surgery like prostate surgeries. These are exceptions, especially the intracranial surgeries where we cannot afford even a small, or surgeries on spinal cord where we cannot afford a small hematoma also. So those are the cases aspirin need to be discontinued. But other than that, in general, in other cases, it is advisable, and as a cardiac anesthetist, even during cardiac surgeries, nowadays we are continuing at least one antiplatelet agent. We are not stopping aspirin as what we used to do, suppose 10 years back and all. We used to stop both the agents. Now we stop the second agent, that is clopidogrel most commonly, and then we tend to continue the aspirin. Other important thing about aspirin is also the dose. Aspirin is given in various doses, starting from 75 milligrams, 100 milligrams, 150 milligrams, or even 300 milligrams. So if it is below 100 milligrams per day, the dose, the chance of the risk of bleeding is less. So the patient is on low dose aspirin, it can be continued. If they are on high dose aspirin, it need to be, either the dose need to be reduced or discontinued for 5 days prior to an elective surgery. So it's very clear. So coming to the dual antiplatelet therapy, because nowadays no cardiologist believes in using a single agent. They always want to use in combination with aspirin another agent, one of these, either prasugrel, clopidogrel, or Brilinta. One of these drugs they always combine, because they say only the combination, their studies, whatever trials they quote, all show that only a combination of antiplatelets agents, two agents, dual antiplatelet agents only, have the effect in the patients with non-cardiac disease. Of course, definitely with the if the patient is on PCI, that's on stent, definitely they'll ask us to continue. So coming to the guidelines, patients who are receiving dual antiplatelet therapy after percutaneous interventions are at increased risk of acute stent thrombosis if antiplatelet therapy is discontinued prematurely. Because if you see the post-procedure notes of any cardiologist, what he gives instruction to the patient, he says, not even for a single day the antiplatelet medication should be stopped, at least for 1 year, even more also. But the first instruction they give is, do not stop the antiplatelet medication. So whatever you say, the patient is not going to listen to you. So their guidelines also say the highest instance of stent thrombosis is because of stoppage of the dual antiplatelet therapy. But our concern here is increased risk of bleeding of these medications. Definitely, when compared to aspirin alone, the combination of aspirin with the second agent like clopidogrel, the risk of bleeding increases many-fold. The combination is very, very synergistic, and the combination of two agents, the bleeding is not double, the risk is not double, it increases many-fold, it goes up by many times. So what does the current guidelines say? Current guidelines mandate the dual antiplatelet therapy for at least 4 weeks after the bare metal stent implantation, and for at least a year after drug-eluting stent. The guidelines are very clear. Minimum of 4 weeks for bare metal implantation, stent implantation. But nowadays, if you see, most of the cases, they are inserting only the drug-eluting stents. Very, very rare nowadays to see. Of course, they are using, but mostly the trend has gone towards drug-eluting stent. So we should actually find out from the patient history what type of stent has been inserted. Because if you ask him orally, he says, I don't know, they have inserted a stent 6 months back, I underwent a stent procedure. So he will not be clearly telling you whether he was a DES was inserted or a bare metal stent. So in the history, we should find out what type of stent has been inserted. So as per the guidelines, elective surgery during this mandatory period, that is 1 year after DES and 1 month, up to 1 month after bare metal stent, is discouraged. Yeah, it's very easy to tell in the guidelines, but can you discourage your surgeon from doing a surgery? Automatically you look for another anesthetist who has guts to give or who doesn't know about this agent. So it's very, very difficult to convince a surgeon that to postpone a surgery you can convince by a day, not by an year, not by 6 months. You can't say, okay, you operate on this hernia or this cholecystectomy after a year. He's not going to listen to you. So we have to find a via media and look at the relative risk of either stopping or continuing with the antiplatelet medication. So what are the recommendations? For urgent non-cardiac surgery. If an urgent non-cardiac surgery has to be performed between 4 to 6 weeks after a bare metal stent or DES, continue the dual antiplatelet therapy unless the relative risk of bleeding outweighs the benefit of preventing the stent thrombosis. So in usual surgeries, we should continue these agents, take a risk. There can be a chance of bleeding is there, which should be explained both to the surgeon and to the patient family that because the stent has been inserted recently, we cannot afford to stop the antiplatelet therapy, but because this surgery is an emergency surgery like a strangulated bowel or appendectomy or a acute cholecystitis, we don't have any choice but to continue with these two agents, but be ready to do the transfusion, or sometimes temporarily we may have to give some platelets also, but which once again is controversial. If you give platelet transfusion, it can also precipitate a thrombosis of the stent. That's about urgent non-cardiac surgery. Okay. In patients with coronary stent and surgical procedure mandates discontinuing of the antiplatelet, that is P2 Withdrawal platelet receptor inhibitor, that's the clopidogrel. Continue aspirin perioperatively and restart clopidogrel as early as possible. So that is the guideline. So in the two agents, at least you continue one agent and start the second agent as early as possible. As early as possible, probably within 24 hours or after 24 hours after surgery, start the second agent, but continue aspirin perioperatively. This is about the other guideline. So for doing all this, we have to obtain a consensus between the surgeon, anesthesiologist, cardiologist, and we should also talk to the patient and his relatives to discussing with them the relative risk of bleeding versus stent thrombosis. So definitely stent thrombosis can be disastrous and can cause a major cardiovascular event where we may even have mortality. So it is better to err on this side of continuing the antiplatelet agents rather than discontinuing them abruptly. Time is over?
Yeah. 1 minute.
30 minutes.
Yeah.
Is it 30 minutes or
5 minutes more.
5 minutes.
5 minutes
Okay.
more.
Okay. Then I'll go through others a little faster, so the controversies are less in this. Okay. Other common drug, as I already told you, most of the patients are on statin, whether they visit a neurologist, cardiologist, or for hypertension or hypercholesteremia, anything. So statins have got important preventive role in stroke and MIs. So what is the benefit of continuing perioperative statin is there is a lower risk of stroke and MI. So advised to continue, but there is a risk of rhabdomyolysis in the perioperative period. So statin should be continued in patients currently taking statins and scheduled for a non-cardiac surgery. The perioperative initiation of statin is reasonable in patients who are undergoing vascular surgery, because vascular surgery patients have a very high risk of having cardiac events perioperatively. Statins can be initiated in this group of patients. Coming to alpha-2 agents, the benefit of continuing them will have a better blood pressure and heart rate control and reduced incidence of perioperative MI, and we can avoid withdrawal syndrome, whereas the risk is always there is a perioperative hypotension can occur, especially with agents like propofol and all. There can be a coming to calcium channel blockers, the benefits are lower chance of risk of death and MI. So advised to continue, but we should be watching for the hypotension and heart failure in the perioperative period. None of the randomized control studies have shown reduced incidence of death or perioperative MI, but only they have shown less incidence of supraventricular arrhythmias and ischemia in thoracic surgery. This is about the calcium channel blockers. Coming to ACE inhibitors, if you continue it in the perioperative period, you have a better blood pressure control, but we all know that they can lead to a little vasopressis and can lead to hypotension, especially in major surgeries. So, advised to discontinue the drug in the morning of surgery. But the guideline says continuation of ACE inhibitors and ARBs perioperatively is reasonable. The level of evidence is B. Class A to 2A recommendation to continue both ACE inhibitors and ARBs. If they are held before surgery, it is reasonable to restart them as soon as clinically feasible. Coming to diuretics, they avoid fluid overload if you continue them, but there is always a risk of hypokalemia and also hypotension, hyponatremia. Coming to digoxin, there are no clear-cut guidelines on that, but usually as anesthetists we tend to discontinue it on the day of surgery because of worry about the toxicity. Antiarrhythmics, you are advised to continue antiarrhythmics in the perioperative period because sudden withdrawal can precipitate arrhythmias. So, to conclude, the perioperative medication management is estimating the risks and benefits of either continuing or discontinuing. It's a double-edged weapon. You have risk if you discontinue, and also you can have also risk if you continue them also. Management must be tailored to specific patient and specific procedures being performed, including neuroaxial anesthesia, analgesia management. Thank you.